the topic that I was charged to discuss was quality of life in patients with spine tumors and correlation with the spinal instability score, the SIN score, and then looking at some cost effectiveness data. So this topic was very much a panacea. There's a lot of information here. And I wanted to start off by saying that it's challenging to look at outcomes. And the reason for that is that compared to, for example, degenerative spinal conditions or deformity, there's much more of a breadth of disease burden here. So when you have disease burden that affects not only your neurological outcomes or neurological system, but pain is involved, disability is involved, and multiple sites of tumor burden are involved, then it makes it a more difficult outcome measure to more easily kind of hone down on in terms of outcome. And also there's the fact that there's multiple different treatment options, and there's much more of a psychological component to spinal oncology and the patients and their treatment algorithms. Now, for the purpose of this talk, I wanted to really focus on metastatic epidural spinal cord tumor involvement, but we will touch base on primary spinal cord tumors as well. So the main goal when we treat patients with metastatic spine disease is really to preserve or improve the quality of life in these patients. And that is to reduce pain and restore function in these patients. So when we look at quality of life, there's two ways of looking at it. One is that it's a physician-mentored or physician-centric pathway to look at quality of life. And so we tend to look at more objective measures, for example, our ECOG scores, our survival rates, so they're dichotomous quantitative measures that we can easily and discretely measure. Or much more preferably is patient-centric pathway for looking at quality of life. And that comes into patient-reported outcomes. So whereas historically we've really centered on things such as morbidity and survival, quality of life, physical function, and pain is now becoming primarily important in terms of gauging success of treatment and quality of life. So basically, there's two ways of looking at our quality of life measures. One is that we can look at general questionnaires to assess the quality of life of patients with metastatic disease, such as our EQ5D questionnaires, our short form 36 questionnaires. And you'll see that there's a plethora of different quality of life outcome questionnaires or measures, most of which are general and not specific to cancer, some of which are specific to cancer, and very, very few that are specific to spinal oncology. So the Spinal Oncology Study Group has developed the outcomes questionnaire. I want to talk about that or touch base on that briefly. Basically, the Spinal Oncology Study Group developed this outcome questionnaire to measure quality of life in patients with metastatic spine disease. And it did it through a consensus discussion of experts in the field and an evaluation of important parameters that they decided were relevant to quality of life in patients with spine oncology. And these things centered on topics such as therapy, post-therapy, social function, mental function, physical function, pain, and neurology. So the initial version of this consisted of 27 questions that were posed to patients, and they were divided in the 6 domains that I talked about. That then required validation, and so the original questionnaire was developed in 2010. In 2015, there was validation of it in these 82 patients who presented with spine mets, but also primary lesions such as myeloma and lymphoma. And the score was validated against this generic quality of life outcome measure, the EQ5D. And it was found to be validated and in fact better in terms of internal consistency and coverage. Now there's a second version that has been released in 2018. The group of experts again looked at whether there was correlation with other quality of life scores, in particular the pain score, the NRS pain score, and the short form 36, and found validation there as well. And they found test and retest reliability with the second version of this. Then the second quality of life measure that I think is very specific to and can be to spine and can be used very effectively in spine oncology patients is that of the PROMIS score. And the PROMIS is the patient-related outcomes methodology score. And there are two papers in particular, and the one I've highlighted here by Bernstein is very effective because it looks at both primary and metastatic spine tumors. And it finds that this PROMIS score, and we'll hear much more of this in general spine with our degenerative and our deformity patients, is that it correlates well with mechanical pain, such as that measured in the oswestry and the neck disability index. And it suggests that it can accurately capture these physical functions. But in addition to that, it also captures pain as well. The beauty of the PROMIS score is that it's adaptive. So, in other words, there's a computer interface. As the patient enters or answers to each question that comes up, the subsequent question is altered to adapt to the responses that were previously given. And it's interface driven as well. So the one outcome that wasn't correlated particularly well was a depression domain, which is part of the PROMIS scoring system. So mental well-being was questioned, and the SOSG outcome criteria, as we'll see, was found to be better correlated to quality of pain. So when we put these things together and we compare the different quality of life patient-reported outcome score, we really find that this article stands out because the aim of the Pereira article here was to determine what the most useful overall outcome score was to measure both physical aspects such as pain, neurological function, but also quality of life. And in particular, it looked at 5 different domains. One was ODI, NDI, PROMIS physical function, in other words, the physical component of the PROMIS score, the pain component of the PROMIS score, EQ5D is a generic quality of life measure, and the spinal oncology study group measure that we talked about. And they also assessed whether the various concepts that were claimed to be measured did in fact correlate with quality of life measures in metastatic spine disease patients. And with respect to quality of life, 2 things stand out here. One was that the spine oncology outcome questionnaire stood ahead of the rest with respect to quality of life. And the second was that the standard error of measurement with the SOSG was significantly better than each of the other questionnaires, meaning that there was more internal validity and reliability with the SOSG compared to the rest. So, in other words, they recommended SOSG for measuring quality of life, but PROMIS score for everything else, including pain and physical function. And it stands out there with having the highest total score. So what about outcomes? How about quality of life improvement from surgery itself? So this paper from Barzilay was very impressive because they followed 111 patients who had the metastatic epidural spinal cord compression and underwent the separation surgery, which we've heard about, which is limited surgical decompression and separation from the anterior column typically that undergoes stereotactic radiosurgery. And they specifically looked at two other outcome measures. One was the brief pain inventory, and then the MD Anderson symptom inventory. And what they found was that in almost all cases, surgical intervention led to significant improvement in outcome. And there were a few factors, however, that impacted postoperative outcome as measured by patient-reported outcomes. One was whether there was neurological deficit and decreased performance status. The second was whether the tumor was in the lumbar spine. And the third was gender. And we'll look at that closely. So basically, if you started with a lower motor score, then you experienced a significantly improved pain measurement as measured by the BPI when you had surgery. So that's not hard to believe. Secondly, lumbar location was better than cervical or thoracic with these measures. And it's probably to do with the pain component as well. And of course, when you start with a worsened neurological outcome or initial outcome, then you have more to gain. So these are intuitive. And again, same with function through the ECOG scores as well. And female gender benefited more than male gender with respect to pain in particular. Now, those patients that had prior surgery at the level of interest didn't do as well. And when it came to reoperated patients, these patients overall improved with surgical treatment, but the improvement was not as much as with native patients. So delineation of these patient characteristics facilitates decision-making, but also discussion with the patient as to what's important. So it really is important for us to understand what measures are important with symptomatic relief and to act on them beforehand. So when we look at other aspects, such as quality of life and survival, when it comes to polymetastatic or fewer metastatic burden, what we again find is that surgical treatment is improves quality of life with both, but it's higher for lesser metastatic burden than it is with polymetastatic burden as well. And we can see that here there was improvement. Sorry for the slide, it's a little bit harder to read, but basically from baseline all the way out to 32 months, there was improvement in the EQ5D scores, whether the patient had few oligometastatic burden or multiple metastatic burden in their spine. What about surgery in general? Well, we know that it improves the quality of life. We know that there's sustained improvement in pain and neurological function as well. And so as a result, it is acceptable in patients who've got a focal asymptomatic lesion who have at least a 3-month survival of prognosis as well. When it comes to SIN score, we know what the SIN score is, but in particular, SIN score correlates with mechanical pain, which is an important quality of life measure. So surgery improves significant improvement, it provides significant improvement in pain, neurological status, in particular to mechanical pain. And this is another study that basically validated the SIN scoring system, but also said that stabilizing cancer patients through the SIN score is consistent with improving their mechanical instability. And this was an important quality of life measure as well. So finally, patient satisfaction with treatment outcomes. This is such an interesting paper by Versteeg. Basically here they looked at whether high rates of patient satisfaction with or without radiation in the surgical group versus radiation alone were reported. They found there was really no difference in satisfaction rate between these two different treatment groups, but there was a greater effect of surgery on quality of life measures versus radiation alone. And there was no improvement in those patients who were dissatisfied for the factors of being single, being discharged at home without family or home care support. So dissatisfied patients reported worse mental health, social function, and physical function scores at 12 weeks after treatment. ideally, the point is that we can modify these risk factors, we can address them to improve satisfaction. And satisfaction is an important indicator, advanced indicator of quality of life measures. Finally, cost effectiveness. We know through a study by Michael Failings in 2014 that surgery is more effective but more costly as well. However, two studies in particular outlined the value of surgery. This study by Miyazaki from Japan again demonstrated that if we look at this concept of incremental utility ratios, when we have an incremental utility ratio that says that a quality of life adjusted year is measured of $50,000 or less, that's regarded to be acceptable and cost effective. And in surgery for metastatic epidural spinal cord compression, this was measured in their group, in their cohort of patients, to be $42,000 per quality of life adjusted year gain. So in other words, it is effective despite being more costly. And then finally, a paper from the United Kingdom found that it was the fact that patients can ambulate more. So for the duration of their life and treatment, surgery is just better value when it comes to treating these patients with epidural spinal cord involvement than conservative treatment alone. Thank you very much.
Noosh, this is Jens. Thank you so much. Great stuff. Great overview. So that said, what are you doing at the wonderful University of Arkansas now? What measures are you going to collect here and now?
Yeah, it's such a good point. So, Dr. Chapman, we are transitioning to this PROMIS score system. We have established it as part of our own registry. We believe that it captures all of the information that's handled through SF-36, the pain, the mental component, the social component, and so on. And it translates well across all spine patients. So for us, it's going to be PROMIS. And we believe in applying that to our surgical patients, which is this hybrid treatment of separation surgery followed by concomitant radiation. So that's the way we're going to go.
How is this playing out? What do you use specifically? So PROMIS has the computer adaptive, the CAT model, has a short form, has a regular conventional paper form. So which of the variants are you going to apply?
Yeah, it's such a good question. So we're definitely interested in the physical component of it. We're interested in the pain component of it. We think that by having a electronic medical record system that captures this information on the front end, we're able to utilize that for our research purposes and then turn around 360 and decide what we need to tune up in the patients ahead of time so we can get the best outcome. So for me, it's all about pain, physical component, and now quality of life.
As we're trying to quantify things, especially in oncologic patients, trying to put some numeric kind of parameters and coefficients onto what we're dealing with is so important. So what I'm still missing is something that expresses the patients, for instance, in the Bilski score or the Karnofsky index or something, the Charlson comorbidity index, because again, the comorbidities are profound. And one thing that I routinely don't see is previous radiation or previous chemotherapy or something like that. So those are variables that are pretty substantial that affect risk assessment and outcomes as well. So thank you.
Thank you. Yeah, thank you.
But what are you doing in that regard then? Are you applying Karnofsky score, or what covariables of patient comorbidities are you registering then?
Yeah, we're not, Jens, to be honest. We're picking it up as in a prospective database that we have in terms of their overall comorbidities. We have not utilized a generic system such as Karnofsky like we have for cranial or EQ5D. But as per the data, these things work best when there's a generic quality of life measure score as well. So for us, it's going to be PROMIS, and when we need to buffer up with other comorbidities, we're going to look at some things such as previous surgical intervention, previous radiation usage, what the pathway was to come to us, and try to come to a 360 understanding of what we need to tune up for these patients. But we're not there yet. I think it's challenging.
Thank you, Noosh. Thanks for your lecture. And Rod has final closing questions, and then we'll lead to the final session.
So Noosh, great job. So let me ask you something. So what are you doing these days for your tumor cases? Are you using titanium? Are you using any of the new novel materials that we showed today? Do you do kyphoplasty, vertebroplasty?
Absolutely, yeah. We have a fantastic interventional service that handles the kyphoplasties for us. We've really got away from titanium. We've used PEEK, expandable PEEK technology as well. I'm not necessarily a fan of PEEK, but we found it to be effective for our radiographic follow-up of these patients. And of course, the carbon fiber technology with the screws and so on are now really getting into our practice as well. The other thing I want to say is that Dr. Chapman mentioned Bilski. We had him come out to us as a visiting professor, and separation surgery, which was one of the papers that we talked about, where we really separate the tumor from the metastatic epidural tumor from the anterior column, has been a paradigm shift for us. And I think that that coupled with good involvement, collaborative involvement of radiation treatment and other adjuvant treatment has meant that our outcomes have been better, even though it's involved us being less surgical. We're not jumping to a corpectomy with these patients with metastatic disease.
And then one last comment. You know, David Bumpus was my medical student in Virginia, so we have spies over there. We're watching you.
He keeps talking about you, Rod. I trump him because I have the Oscuian retractor distractor.
That's awesome, man.
There's a little bit of you here in Arkansas too, Rod.
Yeah, I love it. Well, thanks, Noosh, for, we had 2 days of Dr. Kazemi, so this was a real treat, and I appreciate you taking the time out on Saturday to come join us.
It's an honor to be involved. Thank you very much.